Good afternoon. So the only thing harder than giving a talk before lunch is giving one after talk. After lunch, given that everybody's food is settling, but I'm half Cuban and half Mexican, and I can speak very loudly to wake you up. So I'd like to speak to you about a program of research that's currently in its infancy, certainly compared to some of the other programs we've heard about. In fact, the first randomized clinical trial was published in 2007. So we're learning from, not only from our own work, but also learning from all of you. And having listened to all these great talks this morning, I've already learned a lot about how to move forward in the next stages of this program of research, which is implementation. So Familia Unidos is a Hispanic-specific, family-based preventive intervention. It's been found to be efficacious in preventing and reducing a wide array of problem behaviors, including substance use, and that includes cigarette, alcohol use, and drug use, also HIV sexual risk behaviors, and also internalizing and externalizing disorders. It aims to accomplish these goals by increasing family functioning and increasing parental monitoring of both peer and school activity. So the importance of parental investment in both the school and peer worlds. This 12-week intervention, see, I told you I speak loudly. This 12-week intervention consists of 8 weekly parent group sessions where the parents are taught a number of different skills, including parent-adolescent communication, positive parenting, parental monitoring of peers, that really places the parent in the change agent role of the family. And then also by 4 family visits, which is an opportunity for the parent to practice some of the skills that they learned in the prior group sessions with their adolescent. I don't expect you to go through this, but basically this is just a snapshot of some of the risk and protective factors that the intervention targets. And not only does it focus on the microsystemic or systemic processes, such as the interactions between family and the peer world and the family and the school world, but it also targets some upstream level factors, including enhancing social support networks for the parents and really changing the parents' beliefs and attitudes around issues of acculturation. So throughout the different stages of intervention development, we've encountered a number of challenges and obstacles, and I'm going to tell you how we've addressed some of these challenges, okay? And some of them we were not as effective, but we know what we would do differently now as we begin to think of the next steps. And we certainly have had challenges across our pre-intervention work, our efficacy trials, and also our ongoing effectiveness trial. So we've completed to date 3 randomized clinical trials with different types of populations, all of them Hispanic, but with different levels of risk or severity. We started out with a universal intervention, where basically the criteria were that you had to be Hispanic. Then we moved on and we increased the level of severity of the population to include a selected sample, and most recently an indicated sample of Hispanic youth, most of which were recruited from the school system and had a level 3 behavior problem, which was defined as adolescents who had committed some type of misdemeanor within the school system and were arrested by the school police, and the police or the school administration decided to give the kid a slap on their hand and let them go. And about 10% of this sample from this study was recruited also from the juvenile justice system. So some experience working in that setting as well. These are results that were published just a couple of years ago in JAMA Pediatrics, and this is a study with an indicated sample. I'm not going to take you through this, but the 1 or 2 things that I do want to highlight, which I think has been a challenge for a lot of family-based researchers, is getting families in. And I'm not talking about getting families into the intervention per se, but enrolling families into a study. So here, for this, and actually I'm not even going to try to find the laser here because I'll mess something up, but we were able to enroll almost 80% of families into our study, 80% of eligible families. And part of how we do this, not only in terms of engaging into our study, but also engaging into our intervention, which we have had a fair amount of success with, is not blaming the participant or not blaming the client. And what we have found is that having a clinician delivered the first contact is extremely important, because he or she can tends to develop a great therapeutic relationship with the participant, even if that initial session is on the phone. Here's just a snapshot of what some of our results. These are past 90-day symptoms of alcohol dependence diagnoses. And here we see the effects of the intervention, certainly a much deeper decline in the intervention group relative to the control group. As I said earlier, we've had an impact on HIV sexual risk behaviors. And here we see one slide on an HIV sexual risk behavior, having sex while under the influence of alcohol or drugs. And we see the Familia Unidos intervention being flat, and we see increases over time, which we'd expect with the given developmental trajectory of adolescence. Our mediator has been parent-adolescent communication, which is really consistent with what a lot of family-based interventionists have found. So here's the first challenge, which has actually mentioned earlier today, that of understanding the organizational structure and the fact that the politics is very local. So one piece that's very important to consider within the school system is that the average turnaround time for superintendents in the country is about 2.5 to 3 years. So here we see, actually these are all in the news within the past 3 or 4 weeks now, of superintendents across the country who have been fired, so I hope no one here is related to any one of these individuals. But it's really important to understand the organizational structure, to know that superintendents may be there at the beginning of your study in a school-based intervention, but in all likelihood, by the end of your study or halfway through your study, they're no longer going to be there. So it's important to engage not only from the top down, but also from the bottom up, and to engage at all levels in between. In our case, we decided to do this not only with the levels of the superintendent and the associate superintendent of curriculum and education, but we also did this with the director of mental health counseling. So this is our ongoing effectiveness trial that we have ongoing in half the middle schools in Miami-Dade County. And the director of mental health was actually one of the co-principal investigators of this particular study. So this was part of the negotiation when we all sat around the table and talked about what was important to each side. So she was a really critical member of this research team. And I should say that she left approximately halfway through the study. And it really didn't create a whole lot of disruption, again, because we had not only champions at the higher levels, but we also had a lot of champions right underneath that mental health counselor, and those were the social workers and the school counselors that were delivering our program. So it was an easy sell when that new person came on board for those school counselors and for those social workers to really sell the program to the new director of mental health counseling for the district. Here's a snapshot of our study design, and I'm not going to go through this in great detail. As I said, our ongoing data collection is ongoing. This is a 2.5-year follow-up study post-intervention, and thus far our retention rates look pretty promising. We hope to be able to get to 90% plus by the end of this particular study. So one of the other challenges, and this was identified very early on when we met with the school administration, was that, well, can you really train school counselors and social workers in an evidence-based program in a relatively short amount of time? You know, the work that they do is very important. We don't want them to get drifted to doing something else. Can you do this in a relatively short amount of time? And we said, yes, we can do it in a relatively short time, and we could do it well, and we can train them to do a great job, not only at the sessions, but also in engaging these families into the intervention, which is such an important part of what we do. So we did this, as I said, in a relatively short amount of time, in less than a week. Here you see the mean fidelity rating on a scale of 0 to 6. I should say that it is practically impossible on our fidelity rating scale to get a score of 6. So here a score of 4, or a little over 4 on a scale from 0 to 6 is really quite good. To give you an idea, our interventionists who have been with us for since this program started 10 years ago, average around 5. So really pretty well for someone who was just trained for 4 years. The other thing that we've been thinking about, and I thank Hendricks for this, was starting to think about issues of fidelity. And one of the things that we always hear about is the importance of monitoring fidelity and having a feedback loop that goes back to, in this case, the school counselors, the social workers. But this piece is so very expensive. Actually, it's a lot more expensive than the delivery of the intervention itself, because we videotape all of our sessions, then we have an independent rater watch these sessions 2 or 3 times, and each session is 2 hours, so you can just take into account the amount of manpower, woman power it takes to be able to do this. And we do this for all of our group sessions and for about a quarter of our family visits. And in a sample size of 750, the large number of groups and the large number of family visits times about a $25 an hour rate, you can just see how much we spend in fidelity ratings. So Carlos Gallo, who's at the Northwestern University, and Hendricks and some of our other colleagues have developed a semi-automated system for monitoring fidelity ratings. So this uses existing technological approaches, computational linguistics, and speech recognition software to be able to rate these videotapes. And although this is still very much in a proof of concept, we have established that at least for one of the scales that we've rated thus far, which is joining, we have about 80% agreement between the human rater and the machine. So certainly something to think about as we try to begin to take this program into schools where resources are very limited. The other challenge, and we hear this all the time without exception, we've heard it at probably 23 of the 24 school principals we've met with 3 years ago. Why do you want to do this? Parents will never come. They will never come. We can never get parents to come in. Parents don't participate in PTA meetings. Why would they participate in your prevention program? Is it really worth a shot? And our response is, of course it is. We've been doing it now for 10 years. So here you can see our engagement rates, almost 80%. I should say that this is lower than our efficacy trials where our engagement rates were about 90%. Here engagement is defined as attendance at the first 3 sessions, and the mean number of sessions was about 6.5. This includes the 22% that did not engage. This actually goes up closer to 9 if we limit that to the 78% that did engage. So we've gone back to the school principals and said, see, we can engage parents, and now your school counselors and your mental health counselors have the skills to be able to engage parents to come in, not only into this intervention, but into other school activities. I'll skip over that. Data collection are still ongoing, but we do have some preliminary data in some of our family functioning processes. So what is part of the future? And I didn't put part here because I don't want to get anybody upset, but part of the future of family-based preventive interventions. And I think that we really have to begin to think about e-health or m-health interventions. And this here is a slide actually that I borrowed from Gary Bennett that he presented in one of the NIH DNI conferences a couple of years ago. And the problem with m-health or e-health interventions is that we really have to be careful about balancing reach and efficacy. So at this meeting, Bennett spoke about how e-health and m-health interventions, their efficacy data are mixed and are not as promising as interventions when they're delivered face-to-face. And the reason being is because people log on to watch the first session, and generally it's not engaging enough, and they don't come back. So the biggest challenge, I think, with m-health and e-health interventions, particularly one where there's 12 sessions, is how do you get them in, and how do you continue to get participants in and retain them through the 12 sessions? If you think about it, it's not a whole lot different than our experiences with face-to-face interventions. It's important not only to engage them, but to retain them. So based on this challenge, we've spent the past 2 years developing an internet-based adaptation of Familia Unidos, which we just launched our pilot study and it went very well, and I will give you some of the preliminary results. And this particular intervention can now be done on a computer, on a tablet. Some participants are doing it on a smartphone, on an iPad. And this is true of a Hispanic population living in Miami that's fairly low SES. So if this group has access to a smartphone, to a tablet, a lot of the country does. So here's just a snapshot of what it looks like. So as I said, we have 8 sessions, and now our 8 sessions consist of mock groups and culturally syntonic telenovelas or soap operas. And believe me, they are as dramatic as Hispanics want them to be. At the end of each session, there's that cliffhanger that makes the participants want to come back. Okay? And also, with the mock group sessions, we have an interventionist on our team who really should have been a sales car person, because she can sell anything she wants to. And we videotaped with the School of, in collaboration with the School of Communications, 8 mock group sessions where parents from the community came to participate in this study. And this facilitator led a make-believe group. But as you can imagine, what happened was that these parents from the community really began to form relationships with one another. And it really became not a mock group, but a real group. And our participants have an opportunity to interact, and that's what you see on the right, some interactive exercises that they could click on different things with their smartphone or their iPad or their computer, so that they feel that they're part of the process, which is something that is so central to our family-based intervention program. The family visits are done online via Skype, something that's a little more protected than Skype, but basically a similar idea. The acceptability of the intervention, I'll skip through this because I see I have 2 minutes. This is just one quote of this gentleman that participated in our first pilot, where he said that this intervention has helped him a lot, that he is another person because of these videos and these telenovelas. And it's amazing how really 95% of our families said that they identified with one of the characters in the telenovela. So what is the feasibility of delivering this type of intervention? So you saw earlier I presented one of the biggest challenges of delivering an online intervention. It's the very low engagement and retention rates. Here's the percent of families that engage, and it's 83% of our families came to the first session, and thus far, we're 5 sessions in, and thus far we have 83% attendance at our group sessions. So all of the families that we were able to engage have been retained in the intervention. We've done a little worse. 78% of our families have completed the family visits online. And it may be, as one of our other presenters was talking about, it may be that all of our families do not need the family visits. And Ron Prince spoke about this earlier. So it may be that in the future, we want to do different types of experimental design that can answer the question, for whom do we need these 8 group sessions for, and for whom do we need these 8 group sessions plus the family visits? And some of the methods that are being pioneered by different prevention scientists across the country, including Linda Collins, I think can help answer these very important questions. Here's, I think, a remaining challenge for all of us, and it has been really a central theme throughout this morning. So how do we get others to buy in? So all of us here in this room believe in evidence-based practices. We all believe in the power of family-based interventions. How do we get others to believe it? Yes, there are communities, there are states, there are institutions that are delivering evidence-based practices, but it's really a very small group. Here is a very recent article from our local newspaper. And this struck me because I met with the person who developed this program just really a little less than 2 years ago. And she wanted to see if I wanted to partner up, with her in this particular initiative, with this particular intervention program. And, she said, I'm ready to distribute it to the masses. And I spoke to her about, well, what is the evidence behind the program? At the time, there was no evidence. And there still is no evidence behind the program, but yet it's being disseminated to 30,000 students across the Miami-Dade County Public School system. So here's the clip from the Herald. HIP has worked with more than 27,000 high school students, about 15,000 this academic year alone. And it teaches them about reproductive health, relationship, nutrition, exercise, obesity, alcohol, tobacco, and drugs. So then you wonder, what are others doing that we're not? So if it takes us 10, 15, 20 years to be able to get our evidence-based intervention programs out into the community to reach the masses, how can individuals that started in this endeavor a year and a half ago be reaching tens of thousands of children? Moving towards primary care settings. So we've begun to do this in our research center, and we're at the very early, and I see the red light, I have 1 minute left, so I'll try to close it out. Beginning to think about integrating family-based intervention within a primary care setting. And what we've learned from all of the meetings that we've had over the past 6 to 7 months has been some of the things that already Margot and Ellen have said. Minimal disruption to the system. You can't disturb the flow. We're very busy individuals, and you can't interfere with our time. And finally, is this intervention effective? Is it really worth our time? So if we can do this, I think we have a great chance about integrating and scaling up some of these very effective family-based interventions into primary care settings. Our own team is launching a pilot study in 4 different clinics, some academic centers, pediatric clinics, and community clinics. I want to leave you with this one slide, now that my time is up. And our family-based interventions, and I know I'm sort of preaching to the choir here, but I know this is being recorded, so hopefully this goes beyond this room and beyond academics. So is it worth the investment? Here's an example of just one family-based intervention, and there are many others, as you all heard from in our first panel, that have had an impact on a number of different lifestyle behaviors. Drug use, HIV sexual risk behaviors, even physical activity when the intervention itself doesn't target physical activity, depression. So if an intervention is only a couple of $100s, why is it that it shouldn't reach the masses? Again, if we're willing to pay a lot more than this for medications, why is it that we're not willing to pay a couple of $100s for these type of interventions that have an impact on a number of different outcomes? So what really needs to happen is that I think we need an upstream intervention to be able to change the culture of organizations, of institutions, of communities. If we can't identify and scale up those upstream level interventions at that level, I know Kimberly said 20 years ago we were talking about these same themes and the same conversation. I think unless we begin to think about that, unfortunately, we may continue to have this conversation 20 years from now. Thank you very much.